Professor Ganley. So sorry, we will not have time for questions. We're just going to keep plugging away. One of the key roles of the moderator is to keep the train running. So we'll keep it running, and I'll invite Professor Gilbert from University of Toronto for his talk on functional reconstruction of the oral cavity, of which he is an international expert. Thank you, Dr. Gilbert.
Thanks, Neil. From the outset, I'd like to thank Claudio and his team for putting together just an amazing meeting and for the privilege of speaking. You know, a quick shout out to Jay Shaw, and for those of you in the audience who have not been to a world tour event, this was Jay's vision. It was always Jay's vision. He's executed it, and he's brought all of us together as faculty, and it's been incredibly rewarding for all of us. And here's a picture of Ehab and I sailing in the Bay of Quinte in Ontario, a beautiful place to go sailing, but it's produced lifelong friendships really for all of us. So pleasure to be here. I'm from the University Health Network at the University of Toronto. And for those of you that haven't been to Toronto, the University Health Network is a network of 4 hospitals: the Toronto General, the Princess Margaret, the Toronto Western, and our rehabilitation facility. Princess Margaret is the cancer center and is Canada's largest cancer center. I have the great privilege of working with a remarkable group of people. Some of these names will be familiar to you from the literature. And in our group, we have 6 microvascular surgeons. 5 of them are at the Toronto General site, and 1 is at the Mount Sinai site. So we have a lot of experience with head and neck reconstruction. The purpose of my presentation for the next 12 minutes is to review the principles in oral cavity reconstruction, review our current institutional approach, and there's many reconstructive surgeons in the audience, as we saw from the show of hands. So this is some of our ideas, and then briefly review some new ideas that we've been pursuing in mandible reconstruction, and I'll talk more about that tomorrow. So when we look at where we were 50 years ago when Jay started practice and where we are now, there's been a dramatic transformation in the outcomes for patients in terms of function. Today, the standard is comprehensive reconstruction of the oral cavity, mandible, and dentition. I think this slide, which was created by one of our speech pathologists in Toronto, really highlights the way we should think about functional outcome in oral cavity, and that it's complex, there's many factors, and it's not just the flap. It's obviously the T stage of the tumor, dose of previous radiation treatment, the bulk of the reconstructions, volumes, mobility, sensation, and then the patient's comorbidities, their age, and their ability to have plasticity within their adaptive process. So quite clearly, objectives are restore speech, mastication and swallowing, and that includes dentition, and to recreate the form and function of the face and minimize deformity. And for us, the basic principles: maintain mobility of remaining tissues. If you use a reconstruction that restricts the movement of the tongue, obviously you haven't helped the patient, and we want to try and restore movement, sensation, and all these other features that are illustrated in this slide. What does the literature tell us about quality of life in patients who've undergone modern reconstruction? And I bring your attention to this older paper from the Aintree group in Liverpool, James Brown and Simon Rogers as the senior authors, from 2006, and this was in the era of the development of soft tissue flap reconstruction of the oral tongue. And they used an old methodology, the University of Washington questionnaire, and these are the speech outcomes, as you can see by, is that working now? And you can see that the patients that have extended defects of the oral tongue have the worst results in terms of their ultimate result at 12 months. In terms of swallowing, the same observations. So more extended resections result in long-term functional disability for patients. And interestingly, all patients described changes in their perception of their aesthetics. Well, what do the studies of functional outcome tell us? For us, in our perspective, extended tongue resection, including the base of the tongue, results in poor functional results, regardless of who or what you use for the reconstruction. Volume matching and obliteration of dead space is clearly the best technique for getting optimal functional results for our patients. So thin, small flaps on big defects don't work. And in extended defects that extend into the oropharynx, where part of the palate is resected, very important to recreate the velopharyngeal port to get the best speech and swallowing results. What about sensation? There's been a lot of interest in sensation over the last 30 years. This is a study out of Toronto General, our institution, many years ago. Senior author Brian Boyd, who's a plastic reconstructive surgeon. And in this study, we actually measured and so just to show you the graphic, CLT, get this right. CLT is the contralateral tongue. IRFF is the reinnervated forearm flap to a reconstructed oral tongue, as compared to the sensory discrimination of the natural forearm. And you can see that if you reinnervate a flap, you get sensation that is better than the native arm because of the connection to the lingual nerve. But the big question is, does it have an impact on function? And there's great evidence and ample evidence that we can restore sensation. However, does it affect function? Some authors, Mark Erkin, believes that it does, but most observational studies suggest that it doesn't really have a major impact on function. And we've moved away from reinnervating flaps. So what are the current options for oral reconstruction? And everybody in this room that's surgically trained can do most of these reconstructions. And I'm going to focus on the free tissue transfers. In our institution, we really focus on using the forearm flap and the anterolateral thigh flap, obviously based a little bit on defect size and the patient's body habitus. Increasingly, we're moving to the Tdap flap in patients where we're doing bone reconstruction as well. We've used the MSAP flap with moderate experience, but don't like the reliability of the vascularity of that flap and have moved away from it. We try and stay away from mycutaneous flaps because the volume, the tethering that you get with these flaps really produces inferior functional results. So small defects, we use this array of local flaps, and for more extended defects, mostly free tissue transfer. I wanted to show you a new technique that we've been using, kind of a boutique flap that we've been using in patients that have small flora mouth defects or need secondary reconstructions to untether structures. And that's the temporal artery postauricular skin flap, otherwise known as the TAPIS flap. And the advantage of this flap is you can harvest the postauricular skin on the superficial temporal vessels and have a very thin, pliable defect or reconstruction without a defect in terms of the donor site. And this is the area of skin that you can harvest. It can actually be bigger than this. And this is what it looks like when you harvest it. And you can use it as it was in this case to try and untether the tip of the tongue in a patient who'd had a previous reconstruction elsewhere. And you can see the flap in place in the mouth. And that's the donor site defect. So really no visible donor site defect. So something new that you might consider if you're a microvascular surgeon in small volume defects and particularly in the floor mouth. What are we doing today? As I indicated, mostly forearm and anterolateral thigh, increasingly Tdap flaps in composite defects. What about the total glossectomy defect? Certainly a challenging defect for patients and surgeons. And if we're going to maintain some speech, it requires maintenance of the volume of the reconstruction. Over time and with the use of radiotherapy, we tend to see the flaps sink down into the floor of mouth. And I'm sure many of you have seen that with herniation of the flap inferiorly. So we need to recreate the infrastructure of the floor of the mouth. This is a publication from a couple of years ago based on our experience in using the scapular tip flap with the Tdap flap to recreate the oral tongue and recreate the diaphragm of the floor of the mouth. This is an anterolateral thigh flap, and you can see that over time, although it's a different flap, a VRAM flap, what tends to happen is the flaps herniate inferiorly, producing inferior functional results for patients. The Tdap scapular concept is basically to use the bone, and unfortunately the mouse doesn't work here, but the scapula is placed in horizontally to recreate the diaphragm on the floor of the mouth, and this is what it looks like in a patient. And the picture E shows you the scapula placed right up in and under the mandibular defect, or the floor mouth defect. And interestingly, in all of us, what tends to happen is the scapula is exactly the same shape as that deformity. Well, what about the mandible? What are we doing today? And again, won't spend much time on the principles. They're well known to everybody in the room. I think the current options today are nothing, occasionally in posterior defects and radionecrosis, including the joint. We rarely use alloplasts alone today, and really their only place is palliative management. And certainly the go-to for, and the standard, is free vascularized bone transfers. These are the ideal characteristics of any reconstruction. And today, certainly the fibular flap, as everybody in the room knows, is really the workhorse flap for mandibular reconstruction. And in this era, with the use of virtual surgical planning as the benchmark now for creating perfect occlusal-based reconstructions. Briefly bring your attention to the scapular system of flaps. This is a flap site that we've had a great interest in. There's basically two flaps here. There's the standard lateral border scapular flap supplied by the nutrient artery to the scapula that comes from the subscapular system, and something we've published a lot on, the angular tip scapular flap based on the angular branch that comes off the thoracodorsal. So when we look at the standard scapular flap, and this is an illustration of that, you can see that the problem is the pedicle is very short, and there is not much ability to rotate the skin relative to the bone. And this was a flap I used for about 20 years in mandible reconstruction. It would look just like this. But as you can see from this illustration, there's a vein graft here running from the pedicle to the jugular vein, not because we didn't have other veins, but because the pedicle is short with this flap. The angular tip flap really for us has become the workhorse flap for reconstruction. The angular branch supplies the tip of the scapula up to a length of about 10 centimeters. We've used it extensively in maxilla reconstruction, but are now using it as one of our go-to flaps in reconstruction of the lateral body of the mandible. It also has the advantage of the potential for a chimeric flap. Here's a very large defect, external skin, buccal, oral cavity, and mandible. And in this case, we're going to harvest a mega flap with the angular tip of scapula, a prosthetic TMJ reconstruction. And you can see the volume of tissue, the mobility you've got to move the skin into different positions, and the length of the pedicle. Huge advantage for patients. And this is his result at 10 days. So the contour in somebody who's got a thin back can be extremely reliable. You don't have to take the muscle. You can also do it just as a thoracodorsal artery perforator flap. And these are some late results in our patients. People talk about scapular bone not being appropriate for the mandible. These are all scapulas. You can osteotomize it. So from our perspective, the advantages of the angular tip of scapula are it has a reliable vascular anatomy once you understand it. The vessels are usually preserved even in vasculopaths. It's interesting that that actually happens. In elderly patients, there's very little morbidity. And we've moved away from fibula in elderly patients that need mandible reconstruction because of the issues with their gait. And perfect for combined defects with the creation of chimeric flaps. And skin thickness can be a problem. Positioning can be a challenge, and I'll show you tomorrow how we actually position patients for this flap. Just 2 words on the iliac crest. This is an older flap. We do have some experience with it. We've stopped using it in the last 15 years. A great flap for lateral mandible and midline mandible reconstruction, harvested with the internal oblique to recreate the lining of the oral cavity. And this is an example of a late result in a patient who's had that reconstruction and dental reconstruction. The advantages of it are the bone quality is really excellent. There's great implant options. But from our perspective, the pedicle length can be a problem. You can extend it by moving the bone flap back a little bit on the crest. But the donor site, in terms of pain and hernia formation, has been something that's really stopped us from using it routinely. For those of you that want to see how we harvest these flaps, I'd recommend that you look at this site. This is the TVA surgery web-based atlas of, and this is from the Toronto General Hospital. All of our flap harvest videos are here. It's in the open space. You can review it. You can't download it, but you can see our techniques. And I'm the operating surgeon in all these except the robotic one. So there's still problems yet to be solved in terms of the mandible, TMJ reconstruction. We'll talk a bit about that tomorrow. Loss of vertical height post-radiation, and reducing the cost of VSP applications beyond the first world. And we'll also talk about that tomorrow. Thank you for the podium.